Hi everyone.
Welcome to our podcast, Health Data Decoded.
I'm Ed Hill.
And I'm Samuel Ball.
We are researchers working at the University of Liverpool in health data science, and we are part of CHIL, the Civic Health Innovation Labs.
CHIL's an interdisciplinary team of researchers, NHS staff, local government and charities looking to use data and artificial intelligence to improve health outcomes in a responsible way.
This work, as well as bring innovation and improvement to health, can also help with our social well-being and the economy.
In this podcast, we'll be interviewing collaborators, researchers and professional support staff within CHIL to better understand what they do in their roles to improve health outcomes for the local area.
We'll be delving into questions such as, what are their day-to-day tasks? How did they get into the role that they currently have? And what advice would they give if you are interested in getting into this area of work yourself?
So join us in our journey to understand better how we can use data to tackle global health challenges and local ones within the Liverpool City region. Hi everyone and welcome to Health Data Decoded. My name is Samuel Ball and today, unfortunately I'm alone. Ed has to be at an event, but I'm joined here by Sam Osian. Let's start by just introducing you. So you're a PhD student in health data science. Can you tell me a little bit about how you got involved in the PhD?
Yeah, of course. Firstly, thanks so much for having me. I've been looking forward to this all week. So I think how I first got involved in the PhD. So I never actually really wanted to do a PhD, and that's the kind of funny thing of this role. So I had done my undergrad in politics, worked for a few years as a researcher in the charity sector, then did a master's in health statistics, and I became really kind of fascinated with this language boom of AI, this understanding the nuance and semantics of language. So I was browsing kind of PhDs on the off chance that I found something that really clicked. And I think I was seeing that a lot of PhD opportunities using large language models were very focused on, I guess, the kind of chatbot side of things. And this is what most people are probably familiar with, right? The ChatGPTs, the Google Geminis, the kind of end product. And I think I was really fascinated by actually what happens in the middle of that. What is the kind of understanding we can have of language? How can we use that to essentially extract meaning from large bits of text that generally go under-analysed? And I found this particular PhD under Professor Daniel Joyce, and it was really different. It was around identifying kind of signatures of meaning within text. So, for example, the PhD that I applied to, which is now different to what I'm actually doing, because sometimes that's just how it works, obviously, was around finding signatures of suicide ideation in electronic health records. And I became really fascinated with that because this wasn't building a chatbot, it wasn't building a kind of therapy tool. It was really understanding or making use of what would otherwise be a very static resource. And so I kind of applied for it on the off chance that I might get it, and I did.
Yeah, fantastic, yeah. I mean, it so often happens, doesn't it, that a PhD kind of evolves and changes over time. So you mentioned that you're doing work with Dan Joyce, and he's the leader, kind of the head honcho of M-RIC. So do you mind telling us a bit about what is M-RIC to you and how you fit in with the kind of wider research programme that is M-RIC?
Yeah, sure. So I think M-RIC has put kind of a big strategic priority, as I say, on kind of language modelling, but I also kind of, in my eyes, resists some of these trends that I mentioned before, the kind of chatbot side of things. And it's also very interdisciplinary. It puts a lot of emphasis on different people who come from different backgrounds. And this is really important for me because I'm a social scientist, which is not your typical route into AI, but it's one that I actually enjoy because it means that I'm a big picture thinker and I think about systems and I think about wider meaning from things. So that's kind of how I fit into it, as I see it, is contributing to the multidisciplinary nature of M-RIC and also CHIL.
Yeah, it's so interesting, isn't it, how the kind of social science angle, I think, is a bit underrepresented in AI research. So I know that from my perspective, I do a lot of biomedical image research, and the thing that we constantly butt up against is like the systems and the regulation and how to navigate that. And there's actually not enough research in that area. And I think sometimes people turn up their nose a little bit at kind of the core research and they go, "Ooh,
I think so too.
Yeah, we should measure things a little bit." But it's so important. Like without the core research and the big picture ideas, like you said, the research has got no impact, and it needs to kind of fit into society in a very kind of individual place. So I know that outside of M-RIC, you also do work on a PFD tracker. Can you tell me a little bit about that?
Yeah, so I think this is probably my kind of flagship project for year one of the PhD. So, I mean, first, I guess a little bit of context. So when I was working for Samaritans as a researcher, I kind of became aware of this database, this repository of coroner's investigations called kind of PFD reports. So these stand for Prevention of Future Death Reports. And coroners actually have a really interesting kind of legal power that's not really well known, which is they have the power to identify and write a small report where they identify a systematic failure as part of the inquest. So that's kind of what a coroner does. They perform an inquest. Occasionally, as part of that inquest, they identify a concern, and they believe that that concern, if not addressed, could affect future deaths. Future similar deaths could happen. And so they write these systematic warnings into a PFD report, a Prevention of Future Death report. And since the inception of this in 2013, there have been over 6,000 individual systemic warnings. A lot of the time this takes place in hospitals. So, for example, someone not getting the care they deserve. It could be other settings too. But the really interesting thing is that we're not really learning from these reports. So these reports are sent to a particular recipient, whoever the coroner believes is best placed to action these reports. But beyond that, what we really want to do as researchers is we want to be able to connect the dots. So if a systemic warning has been raised by one coroner in one part of the country, in one specific hospital, and that same or similar warning happens in a different part of the country, and another warning in a different part of the country, we currently have no system that allows us to identify that there is a recurring issue that keeps happening. And that's kind of a disaster for public safety, because if we're not learning from these coroner warnings, then, the potential of saving thousands of lives is kind of going missed. And I didn't like that very much. I thought that was such a missed opportunity from these reports that were kind of collecting dust. And so I used my experience in being able to create AI pipelines using large language models and created a system where we could identify recurring issues, recurring themes. So I've developed a toolkit, a kind of interface where people can take these reports, so 6,000 reports. They can firstly filter them based on a particular criteria. So, for example, if you're doing research in suicide prevention, or if you're doing research in medication-related deaths, you can search these reports in natural language. You kind of imagine typing into an interface saying, show me all reports related to deaths resulting from buying medication online. It can be as niche or as broad as you want. And what my interface will do is it will crawl through each of these reports, and it will pull ones out that matches your criteria, your search query. And it does this in a matter of minutes. So it takes a process which otherwise would have taken a few months, maybe even a year to do, of going through each report thinking, oh, is this useful? Yes, no, and kind of having a pile, which a few researchers were doing, and it was taking them a very, very long time to do it. So we've now moved from a stage where we can query this database and get some tailored reports ready for research. But my toolkit doesn't really end in just the kind of search interface. It also discovers thematic clusters, so issues that keep on happening within these reports. And it also allows us to pull out structured information. So what a lot of people are very interested in, what a lot of researchers are interested in, is not just looking at these reports globally, but doing some kind of subgroup analysis. So, for example, looking at reports that are concerning a particular age range, or gender, or disability. These attributes aren't explicitly recorded as their own section in PFD reports, but they may be written as a kind of like an aside by the coroner. And so what PFD Toolkit can do is it can pull, kind of like, finding a needle in a haystack, it can pull the most salient information out of these reports in a way that can be completely customized by the user. And so the idea is that you take this unstructured database and you transform it into a neat tabular data set ready for research. And so what we're really hoping is that these reports can be used a lot more in research, because I think there's only like a dozen or a couple of dozen of research papers that have ever used PFD reports, these really important, coroner's warnings. And you compare that with Australia and New Zealand, where they have a really rich system for this. They have a lot of research that's available through their database. They have a function for actually extracting meaning from this. In England and Wales, we haven't had that. And so what I'm really hoping is that this is now the chance we have to be able to actualize these reports. Yeah. I should say that I'm not alone in this space. There's been some fantastic works, for example, from Dr. Georgia Richards, who's an Oxford academic who created the Preventable Deaths Tracker, which is a way of analysing the metadata of reports. So, for example, the location, the individual coroner. What my software does that is different is it allows us to engage with the meaty textual sections of these reports, these unstructured bits, which is a kind of new precedent for research in this area.
Yeah, I suppose as well in some ways it's a bit like having a superpowered search engine to go through. You've obviously got 6,000 documents, and each of these documents, from what I saw, was very long. It was 10 pages plus, and a lot of it is kind of legalese jargon that dances around a bit of a topic, and all the information is in there, but it's not kind of on the front page. You have to kind of do a little bit of digging. So having this kind of system where you can interact with it in a more natural way, it's quite clear how it helps. I know I've done a little bit of work for the clinical trials team in our department, and the amount of data that they work with clinical trials is absolutely huge, and it's all buried in like text and this information, and there's subtleties when you talk to people about, oh, this is different to this, but it's so subtle that someone who's not an expert, someone like me in clinical trials, wouldn't really understand, and that's what they kind of want to get out of it. So it's really interesting, isn't it? But I also want to wonder, so like when we do any program or any kind of AI stuff with data, there's always some kind of like difficulty or some unexpected hurdle that we kind of look to overcome. What was that for you for the PFD toolkit?
So probably a kind of more unexpected one. I mean, firstly, to go back to the point you raised before, you're completely right. There's so much nuance in language. Yeah. And for example, in PFD reports, what could ordinarily be a barrier is the unique way that each individual coroner might write. So coroners don't have a shared dictionary or thesaurus. And this would have been a really big problem for traditional methods. So, for example, I mentioned before, sometimes we might want to pull gender or sex out of these reports as a kind of column in a data set, so we can analyse gender differences in recurring themes, for example. But a lot of the time, the coroner doesn't explicitly write the deceased was a 26-year-old female. Yeah. But they might use gendered pronouns. Yeah. They might say she was a, etc. Similar for age, they might not explicitly say this person was 18, but they might say this person was a young person, this person was a child. Or they might actually just write gender and age as explicitly as that. Yeah. So the challenge for traditional programming is to, was to preemptively find as many different ways as coroners might refer to something as possible, which I'm telling you could be a 2,000-line script, which is looking at, regex patterns of every single combination that a coroner might possibly utter in their report. And so the kind of mission for this project was to use language modeling, which understands not just specific words, but also words in context, sentences in context, to be able to pull out that information even when it's not particularly clear and not particularly explicit. And, as an example, something that we've done this currently a preprint that's out there is we automated a research project that the Office for National Statistics did using PFD reports. So they were interested in child suicide cases. And so they manually trawled through thousands of reports and identified any cases they could see that were to do with child suicide deaths. But while their manual methods identified 30 or so, using PFD Toolkit, we identified over 70, so like twice as much. More than twice as much, and it's because we can find, or AI can find, this needle in a haystack information in a much more reliable way than humans can manually. But I think to I guess actually answer the question you asked me, because that's the challenge. But the most challenging bit for me as a programmer was actually not to do with the software design itself. It's to do with the communication piece, showing people how to use it, why it's important. Yeah. Because I'm introducing people not just to my tool, but actually to PFD reports as well, because these are not an appreciated data source. So I actually have this kind of dual mission of showing, hey, these reports are really useful, and also, hey, my tool's a way of operation, put them into practice. And I think another really big challenge was the design of an interface. So it's all well and good for me to be able to create a software that coders can use, but most people in the health space are not coders. And so I've obviously needed to create some kind of visual interface, some kind of web app so people can interact with this software. And I think what I have found really interesting is creating something really intuitive and easy to understand at a glance. So I've kind of, I mocked something up. I did a bunch of informal user testing with colleagues and friends. And, when you design something like this, you have a really clear kind of user journey in mind. You can think, okay, so someone will go onto this app, they'll start here, and then they'll click onto this, and they'll click onto this. But you do a bit of user testing, and you realize someone else goes in a completely different direction, and then they get confused because the kind of narrative flow of the software that you design is not quite in keeping with what they actually do. And so the most challenging bit for me has been, I'm starting to appreciate the software design is in many ways kind of behavioral science in disguise. There's a lot of that psychology that goes into interacting with software. I'm really comfortable when it comes to understanding the problem, and then programming a solution. I've been less comfortable when it comes to actually creating tangible interfaces that people can use, and that's been the biggest learning experience for me in this.
Yeah, I mean, it's crazy, isn't it? Because in some ways you can do all the research you want to, but I mean the child suicide is obviously an absolutely huge problem.
Yeah.
And the fact that you're able to kind of signpost to over twice the cases that need investigation, I mean the impact there is clear, but then being able to communicate that and put that in front of the people who can actually make the changes to kind of try and solve the problem, that's really challenging, because the people who can solve that problem are not likely to be the kind of people who can do a Python script or something. So that kind of interface is so difficult. So I know that a lot of people at the moment, large language models and AI are kind of what's on everyone's lips at the moment. Do you have any kind of general thoughts about where you think the future of large language models is going? I know we talked about it on the way here, and I think the problem with it is that everyone has so many opinions about it. But I'm always keen to kind of know about people who are experts in the field. Where do they think it's going?
Yeah, I think it's complicated. I think it's nuanced. I think the first thing to say is I think that AI is different from large language models. Language modeling is a component of AI, and it's one that is incredibly dominant at the minute. It's also one that has seen a huge amount of hype and I think misplaced applications in it. So I don't want to sound like I'm an AI skeptic. I'm far from it. I think that, that'd be a slight problem for my PhD, which is all about all about applications of AI. But I think that the problem with LLMs, and I actually draw a comparison with maybe the dot-com bubble. So the dot-com bubble was I think in the mid-90s, maybe early 2000s, where people became very enthusiastic about any company, any organization that had a website. People believed that just simply having a domain with .com at the end of it would really equip your business to make a lot of money. And so these organizations that were quick adopters of having a website saw a lot of funding, but crucially this funding was speculative funding. It was funding on what people hoped might happen, not what organizations were actually delivering. And so what happened was a huge amount of funding was put into these organizations, and over time it became clear they weren't going to deliver on any of the anything that the funders hoped they would. And so the kind of bubble burst. And I think this is kind of really similar to what we're seeing with large language models. So it's seen, to say a lot of funding feels like an under-exaggeration. OpenAI, which obviously make the GPT family of models, including ChatGPT, spend more money than a small country. So it's gone beyond quite a lot of funding. It's huge, it's vast. But similar to the dot-com bubble, a lot of this is speculative funding. Organizations that have been early adopters of LLMs have not seen a return on investment. And so the funding is coming from not what is happening in the here and now, but speculation over what might happen in the future. But the problem is we're kind of reaching a little bit of a peak. So we haven't really seen any big innovation with LLMs that has led to an improvement in accuracy or being able to do things you couldn't with language in the past maybe year or so. And so what we're seeing, I think, is an industry that is slightly panicking because we're now seeing, well, it was always an element of jargon with this. We're now seeing a lot more jargon. So suddenly we're having multi-agentic systems kind of rammed down our throat. What does that actually mean?
Yeah.
It's, I think, we said on the way up, it's a definition that is so broad that realistically you can fit anything into it. And these things are being done not by accident, I don't think, but because I think it's maybe a bit of a panic for how, when there's no new innovations that are coming, you have to kind of manufacture that yourself. The industry has to manufacture that to keep the speculative funding coming. But I don't believe that, if industry hasn't seen a return on investment for LLMs now, I don't believe with the pace or rather lack of development that they're going to see a return on investment further down the line. But the reason why I still don't call myself an AI skeptic, despite all of that, is just in the same way as the .com bubble bursting didn't end the internet, I don't think the LLM bubble bursting is going to end good applications of AI.
Yeah.
And I think this is where people like us come in. If that's not too arrogant to say, is I think when you do really good work with LLMs that is grounded and is rooted in a clear problem. Because I should say as well that a lot of organizations that are adopting AI, they don't actually have a problem to fix. They're seeing the rise of AI, they're seeing the rise of LLMs, and they're seeing other organizations doing it. And they're thinking, ooh, if they're doing it, we should probably be doing it.
It's a bit of FOMO.
Yeah, exactly. And I think this is, an issue that NHS trusts are dealing with. I think this is an issue that I've seen in the charity sector, a lot of organizations are dealing with. People are reaching out to AI, but they don't have a clear problem to solve. So I think that when this bubble bursts, and I think it inevitably will, I think what will remain is applications of AI which are maybe not, headline grabbing. They may not be claiming to kind of, I don't know, wash your dishes or cut your, to mow your lawn. But I think they are solving a really clear problem that's established. And I think I kind of draw a parallel because we're seeing in even reputable journals like Nature, we're seeing applications of AI which sound amazing in a headline, but you look beneath the surface and you're kind of thinking, oh, okay, that's a technical achievement, but not necessarily a practical one. So, for example, I saw an article in Nature recently which had this really exciting, bold claim, which is, hey, we've created an AI that can predict which diseases you will have 20 years down the line. Yeah. And that immediately makes you think, wow, that's kind of incredible. And what it does is it uses language modeling to learn essentially patterns of outcomes that are recorded in electronic health records. And it learns what I think it claims to say is a kind of grammar of diseases. And so it claims to be able to predict accurately, playing fast and loose with the word accurately, in my opinion, diseases that you'll have 20 years down the line. But if you look kind of beneath the surface, it's able to assign a higher risk score to diseases for a lot of people. But a higher risk score doesn't necessarily mean a clinical decision. And this is also an issue with AI at the minute. Sorry, I feel like I'm going through so many different avenues. But AI prediction is not the same thing as a clinical decision. And this is something that really, really gets missed a lot. So clinicians have to work in a really messy real-world environment where they don't just look at the most probable outcome for a particular patient, say a disease that a machine learning algorithm predicts, or hospital readmission risk or something like that. It's not simply predicting that, but it's looking within real operational constraints. So, for example, in mental health, you could have a machine learning algorithm that assigns high risk, medium risk, low risk for suicide ideation among people with depression. And so as a clinician, you might consult that when thinking of whether you want to discharge a particular patient. And it might, assign a medium risk or low risk label to this person. And you think, okay, it's probably safe to discharge them. But actually in practice, we know that a really big issue is crisis follow-up care. if you can't get crisis follow-up care within, I think it's 3 days, then that in itself is a big risk factor for suicide. Similarly, being already enrolled in a talking therapy, a clinician might deem, okay, they have access to support that's not emergency services, that's not crisis services. And so they weigh all of these various, contextual factors up and make a very complex, very nuanced decision. And that's very different from an AI algorithm that says, high risk, low risk, medium risk. Yeah. There's a nuance that's not captured there. And I'm kind of endeavouring to find the point that I started out on. But what's my point? That a lot of applications of AI are severely lacking in that regard. But I'm not trying to say that from a kind of ivory tower, a place of arrogance. I certainly don't believe I'm the only one that's doing really good with this. I was kind of browsing LinkedIn the other day and found a really, really interesting piece of research by a independent researcher called Leon Shaloon, I think his name is, who essentially was able to find mathematical patterns in a prompt that you might give a language model that would lead to hallucination. Hallucination being when a large language model like ChatGPT essentially makes up information. And so it was able to predict at the prompt level situations where may lead to incorrect information being given. And that's huge, because something the large language models can't do right now is say, I don't know. It's something it won't do. But because of this independent researchers' contributions, we are one really, really big step closer to actually having LLMs that say, I can't answer that, I'm not sure, I'm sorry. But that, while this has gained some attention online, it's it's only been in preprint. I'm not sure if it's going to go anywhere by any reputable journal. But despite it being an independent researcher, it's an incredible piece of work. But in Nature, which is often seen as something of a big aspiration for any data scientist to get into Nature, articles that may be published there are not consistently useful or don't consistently have a clear application. And so it's really difficult for people who are interested in AI but don't want to surrender themselves to the hype to look beneath the surface and find sources of information that actually could have some application in clinical settings. And I think, what I would say to anyone who wants to engage with AI, who wants to understand or read more of the research, but is a bit dubious, rightly so, of some of the hype, is, you find individual researchers whose vision you really buy into. And don't necessarily go for what's in the headlines, because I think what's in the headlines is in many ways an artifact of the hype that has come from big tech, not necessarily an artifact of the real clinical need.
Yeah, it's really. I mean, you said so much there. So many points. No, seriously, so many points, and they're all great points. I mean, I think the point about things being a bit hype driven at the moment, but there also still being quality health research that's being done underneath, and we shouldn't throw the baby out with the bathwater. In that there's a lot of I wouldn't call it dodgy research, but research that's kind of led more by marketing than by actual health outcomes. But there is, I think the work that you've talked about today about the preventable deaths, I think that's very clear what the potential impact for that is. And I think when we look at some of the other projects that are being done around mental health or within CHIL about even just access to data, that is something that's so important that a large language model might use. I think, though, that the interesting thing there is that when I've had conversations with other CHIL projects like Data Interaction, the Data Action Accelerator, it's clear that the large language models sit they're ready to go, and they're actually so hungry for kind of data applications, and the actual clinical data is still kind of being worked on, and access to that data we still need to work out. So in some ways, the question is also, how do we get the right data to the large language model so it can work? But yeah, there's a huge amount of hype there as well. So yeah, I think there's a lot to think about there.
I think that's a really good point on access to data, but also access to high quality data. I think a lot of people are optimistic with accessing data a lot of the time, and in computer science I was going to say there still is the saying of garbage in, garbage out. But we seem to have forgotten that with some of these more advanced applications. We almost think that if our technology, if our method is really, really, really complicated, the outcome must be good. It'll all work out somehow. But electronic health records, I actually find a really interesting case, because I agree absolutely that we need to be making more use of these. It makes sense that if a clinician is recording information about a person over a very, very long period of time, you can learn from that. You can pull out information that can allow future clinicians to provide much greater continuity of care than they can currently. But we also have to be really, really critical with our data sources, because with electronic health records, they are in many ways an artifact of the clinical process. And what I mean by that is we kind of hope that electronic health records are this kind of organic commentary of everything that the clinician and the patient has talked about, written up into a nice, neat way. But a lot of the time, clinicians operate within quite a scary context. So clinicians, a lot of the time, are quite scared of clinical negligence claims. A lot of clinicians have either been in a coroner's court where they have been grilled, or they are scared of being in a coroner's report where they'll be grilled. And so what this means is that a lot of the time, clinicians are forced to act quite defensively in what they write. So a clinician might identify a particular treatment or a particular diagnosis, and then they work backwards to record in the electronic health records, as a defense, why that was the correct thing to do. And so they don't necessarily want to afford too much credence to what alternative hypotheses could be, because they know that could be read out in a coroner's court and used against them. And so that's kind of what I mean by electronic health records being an artifact of the clinical process. And so if you take health records then, which maybe contain a lot of data, but not necessarily representative data of what's been discussed, then your outcome is not going to magically be infallible. It's not going to be flawless. It's going to carry that almost selection bias of the original data into its conclusions. And so if we go too big too soon and create these applications, these AI applications using data sources like these, and use it to inform every facet of care, then we'll only end up institutionalizing issues that are really kind of plaguing our health systems, the NHS in the UK. That's not to say that I don't think we should be working on these. I think electronic health records are an incredible source of information and can surface so much pertinent detail that allow us to provide care. But we need to have that critical lens on anything to do with accessing data and not pretend that our methods are magical.
Excellent. Yeah, fantastic. So thank you so much for talking to us. We always ask one question at the end. So all of us are involved in health data research. If you could speak to someone at home and they wanted to get into health data research, how would you recommend that they can take part?
I think there's a strong conception that to work in healthcare, you have to be of a clinical background. And I think more and more we're seeing success stories that come from multidisciplinary spaces. I myself am a social scientist, obviously. You have people from computational backgrounds. People from scientific backgrounds have been able to do, like even physics, have been able to do fantastic things with creating physics-informed AI algorithms. And so what I would say to anyone is don't write off a career in health research just because you think that your background doesn't fall into the classic progression. Anyone will undoubtedly have experience that will benefit the research process. And I have also seen a lot of people who have come from unusual backgrounds like social science almost being quite apologetic for their background. They almost see it as a weakness. If only I studied data science in undergrad, I could have been a better data scientist later on. But what people don't appreciate is the success in diversity of skill sets sometimes.
Definitely. It's so important, isn't it? It's so important. Brilliant. Well, thank you, Sam, for coming onto the podcast. If you like the podcast at home, you can subscribe to our YouTube channel or our Spotify channel, and we'll see you next month.